So I'll be giving a quick, sweet, small presentation, crisp, in context to structural or interventions, TAVR only, the hemodynamic structural deterioration of these structural valves versus a surgical valve. Let's see the data and how at times, in some subsets, the TAVR is definitely faring much better as compared to surgical AVRs, and why it is so. So TAVR has done well. Uh, TAVR has done quite well and even better than surgery in areas like survival and stroke. In only one aspect, the pacemaker implantation rate, the TAVR was showing high frequency of pacer implantation in the earlier years, but that thing is now again not there. So as compared to surgery, this was one point, but now again the graphs are quite comparable. One area where TAVR has consistently shown better results, and that's the point of focus today in my presentation, is that TAVR provides a better flow hemodynamics as compared to a surgical valve. So which means a larger effective orifice area, lower gradient, and a lesser patient prosthesis mismatch, which we call as PPM. PPM was a figure coined first of all by cardiac surgeons only, because we deal with so many patients who had surgical AVRs, and if you see carefully, their usual gradients are 20 to 25 mean gradients. And the reason, if you see the surgical AVR size, they are usually 21 or 23. So usually they have been implanted a smaller valves. This is quite common, quite frequent thing which goes on with the surgical AVR, and that leads to more gradients and a higher patient prosthesis mismatch. Patient prosthesis mismatch actually means that as per a body surface area of that patient, there has to be a certain specific aortic valve area. So now if that aortic valve area is not matched as per a body surface area of a patient, it's a patient prosthesis mismatch, which is very, very common affair post surgical AVRs. So hemodynamics is important. Now getting back to basics, we know here that once a AVA starts going less than 2 centimeters square, the gradients they start going up, and especially they rise steeply after an area less than 1 centimeter square. And this is the same graph which tells the same thing. And this is a TAVR versus SAVR. So in terms of aortic valve area, this is the blue one is TAVR and this is SAVR, the red one. See here, now this is aortic stenosis less than 1, and both the procedures have been done. Now TAVR gives a better orifice area acutely at the time of discharge rather than surgical. And even if we keep tracking these patients for longer time, at 2 years also, now surgical AVRs, they start declining in their performance. At 2 years also, the area becomes lesser, while TAVR is doing absolutely fine. So this is one aspect which is very important. The PPM impacts mortality and a structural valve degeneration. So how? Now, if a smaller valve is implanted into a patient at aortic position, in the long term, it's going to impact a structural valve degeneration and a mortality too. So mortality risk is higher than 1.2 times in severe PPM. So these like patients where index effective orifice area is less than 0.65 centimeters square per meter square, there is a 20% increase in mortality. Similarly, the rehospitalization and a structural valve degeneration. Look at this. So a lower valve into aortic position is going to give that valve degeneration. If it's a bioprosthetic valve, of course, I'm talking of a much earlier degeneration as compared to a good sized aortic valve. Gradients more than 20 are associated with increased cardiac rehospitalization in TAVR. So $1 million question is long-term durability and threat of structural valve degeneration gaining importance as we move to a younger or lower risk patients. So obviously, once we're talking of doing TAVRs in 45 years of age or 50 years of age patients, we are looking at a higher durability. Then it is more important that we give them a good open valve which has lesser ppm. So evidence exists, a smaller effective orifice area and a higher initial mean gradient, more likely or sooner the patient will develop structural valve degeneration. It would therefore make a sense to achieve a highest effective orifice area and the lowest gradient possible. Now, what are the factors which lead to structural valve deterioration? Moderate or greater hemodynamic structural valve disease deterioration. Okay, so mean gradient, if it is more than 20, mean gradient of 10 and change from the baseline, or moderate to severe intraprosthetic AR. So these are some of the pointers which would definitely enhance or speed up the structural valve deterioration. And these are the valves which are available. In fact, if we talk of India, we have now 3 valves. Evolut is from Medtronic, and we have MyValve from Merrill, and Portico is also entered into the area, and this Edwards valve Sapien is also there. There are actually 4 valves. So if we compare these 4 valves, let's see where we stand in terms of achieving a good effective orifice area. Now this is a study with the balloon expandable valve. Now this tells that moderate or severe hemodynamic structural valve deterioration during 12 months of follow-up. Primary endpoint was this, to test this valve in 691 patients, and the primary endpoint was observed in 10% patients after TAVI. So use of 20 millimeter valve-in-valve procedure, or oral anticoagulation were independently associated with hemodynamic structural valve deterioration. So balloon expanding valves have more tendency, or probably more vulnerable for structural valve deterioration. The reason being same, that if we compare the self-expanding valve, which is a Evolut valve in Indian scenario, and a balloon expanding valve, then Evolut valve is faring much better, as it provides a better effective orifice area. This is a trial which shows that the reasons are 2, because Evolut has a supraannular valve structure. So there is the space where the valve is opening is much more than a constrained anatomy of aortic valve. And these are the data which clearly proves that. The Notion 8-year trial, which showed clearly that if we compare core valve TAVR versus SAVR, the TAVR has significantly less hemodynamic structural valve deterioration at 8 years. Similarly, other studies with same self-expanding Evolut valve, Italian registry, Dush 7-year experience. So these all tells one thing very categorically, that structural valve deterioration is less common, is much lesser as in self-expanding valves, in Evolut valve, as compared to the balloon expanding valves. This is a randomized trial choice. At 5 years, it tested again the same results. So design matters. So this is the design of Evolut. And as I mentioned, it has a supraannular valve position. So the closure point is supraannular, and that gives a better effective orifice area. So this is at 1 year, it's 2.2 versus 1.7 in a balloon expanding valve. So clearly this is working. A classical example of how the valve selection impacts the results. This is one case which I have done. It's a 56-year-old patient, low EF, hypertrophic ventricle, refused for surgery due to comorbidities, and patient was high risk. But then at sometimes we come across such type of patients where the age is lesser, but somehow they are comorbid and surgery risk is high. So in these patients, it is very important to select a valve. At least we require a valve which is more durable, which will give a better areas for a longer period of time. So that's the reason in this case, as we discussed, if we have to do relatively younger patient, clearly Evolut are scores an edge over the balloon expanding valves. So this is the case, as I mentioned, the young patient, longer lifespan, active life, bigger effective orifice area, valve contributing to lower gradients, and the structural valve deterioration will be lesser for a longer period of time. And a future coronary access is also a point. one has to be careful. But now with this valve, we are doing a commissural alignment deployment, and that also helps in keeping the future thing open. So this is how we prepare. Please excuse me for 10 seconds. There is some urgent call. हाँ प्रशांत आ गया ना बताते रहा हूँ ये तो बताया हुआ okay so this is how we actually do a CT analysis and these are the CT pictures and see the it looks good here. The coronary ostia are very spacious, the lengths are good, sinusoidal salva again spacious, and not being very this patient has no bigger issues. It was only that relatively this patient was younger and less calcium. Less calcium is also detrimental for TAVI. So it has to be a good calcium. I mean, extreme calcium or less calcium, both are not good. Non-supportive anatomy, dilated anatomy, young patient. This is how we went ahead with the procedure. It was quite a horizontal aorta, and then we dilated. It was slipping. We had another dilatation at the aortic valve with the balloon. So all these aortic valve, what means balloon dilatation, we do under rapid pacing. It tends to slip off, but more or less okay. Then valve in this horizontal anatomy is also not easy. Deploying the valve, it tends to pop out, and we kept on trying. We had to retrieve the valve multiple times. It was a tough anatomy from that point of view, and finally we achieved a good position and deployed it. This looks a good position here, almost 3 below annulus, but then towards the end of procedure, a significant thing happened. Now this valve slightly popped out after few minutes of deployment. Now again, at times we come across many tough decisions. So this is the valve now looking like this. We kept on checking with the echo, no gradients, no leaks. Although on one side, if you see very carefully here, on the side of pigtail, the valve is seemingly missing the annulus. It came out. We actually deployed it lower down, but then we kept on checking whether we are missing on anything. Is there a leak or the gradients are going up? So finally, we took a decision that we are leaving it there only, as somehow it got good entanglement and good positioning of the valve, and it was not moving beyond that. We checked in transesophageal echo. Later on, we did a repeat CT, and this actually procedure was done about 9 months back. So patient is doing absolutely fine. We did 3 repeat CTs. So it is at the same position. I'll show you the position. So patient was highly symptomatic. Now he is walking 6 kilometers a day, feeling very healthy and very happy. Now this is the CT picture. On one side, it is just above the annulus, but somehow it got caught in a good entanglement of the thick fibrotic cusps, and it was doing okay. So this was very good decision now we feel, because otherwise if it pops out, you have to have another valve, which is very tedious. So we took a good decision, and that's what I was actually pointing to first case, that at times we have to take different decisions which may do well for the patient in long term. So hemodynamics are increasingly important for TAVR as we move to more active patients. Smaller effective orifice areas and higher initial mean gradient, the more likely and sooner the patient will develop structural valve deterioration. And effective orifice area of at least 2 centimeters square is a worthy goal. And as I mentioned, out of all the options we have in India, I think Evolut are scores best over these points in this context. And this is one way of choosing the valve in relatively younger patients. Thank you.